I'm just going to make sure the share screen is working now, and it is. Fantastic. Okay, I'm presuming that everyone can see my slides. I just want to thank you for the honor of this invitation today, and I'm sorry I can't be there in person with all of you, but hopefully this will be the last virtual Earl Davie Symposium. So as mentioned by the person who introduced me, and I'm sorry I didn't catch your name, my talk today is on prevention and management of post-thrombotic syndrome, a scientific update. This is my disclosures slide. So in terms of an overview of today's session, we're going to be talking about the post-thrombotic syndrome, sort of going through the latest literature in this field. And I'll be talking about what's known about risk factors for PTS, how to prevent it, how to treat it, excuse me, and with a focus on evidence-based published guidelines. And I'll be drawing from several recent clinical guidelines that have either solely focused on post-thrombotic syndrome. For example, this Circulation 2014 guideline that I led. More recently, there was an update to the chest antithrombotic therapies guideline in 2021. It's in press now, that addressed some aspects of post-thrombotic syndrome. And the ASH guidelines on management of venous thromboembolism published in 2020 also address some aspects of the post-thrombotic syndrome. So prospective studies have shown us that the post-thrombotic syndrome actually occurs in about 20 to 50% of DVT patients, and it tends to be severe in 5 to 10% of these patients, in spite of these DVT patients receiving optimal anticoagulant therapy to treat their DVTs. This condition is very costly to society in terms of medical expenses and workdays lost, and also has been shown to reduce quality of life and cause disability and suffering to patients. In terms of the typical clinical features of PTS, the most frequent leg symptoms include heaviness, pain, and swelling. And you can see on the right side of this table, there are a number of signs to look for in the limb, like edema, telangiectasia, venous ectasia, hyperpigmentation, etc. And in general, the symptoms that patients experience tend to be either intermittent or persistent. They're usually aggravated by standing, walking, and usually improve with rest or leg elevation. And really, PTS is a spectrum because the manifestations can be anything from mild clinical symptoms or signs in an individual patient, all the way to severe chronic leg pain, edema, and leg ulcers in a different patient with post-thrombotic syndrome. So it really does represent a spectrum across patients. Just a brief word on the proposed pathophysiology of PTS. So in general, it's thought that the pathophysiologic process ultimately is venous hypertension. And venous hypertension is caused by the outflow obstruction that occurs during acute venous thrombosis, combined with venous valvular reflux, whereby the delicate vein valves get damaged primarily by the acute inflammatory response that occurs as a result of acute venous thrombosis. So all of these processes together lead to venous hypertension, and it's that venous hypertension that causes the pathognomonic symptoms and signs of the post-thrombotic syndrome, excuse me. So I think if we want to talk about preventing the post-thrombotic syndrome after deep vein thrombosis, the first thing we have to consider or understand is what are the risk factors for developing PTS after deep vein thrombosis. And keeping the pathophysiology of PTS in mind, we can divide those risk factors into the DVT itself, other risk factors that are apparent at the time of DVT diagnosis, risk factors related to how we treat the acute DVT, and then risk factors that can become apparent during a follow-up after DVT. And these are kind of the four categories, the broad categories of risk factors for post-thrombotic syndrome, and we'll delve into them a little bit more deeply in the next couple of slides. So in terms of risk factors that are apparent at the time of DVT diagnosis, a really important one is DVT location. So the risk of PTS is higher with more anatomically extensive DVT, such as those that are proximal and especially those in the iliac or common femoral veins. If one has already had a previous DVT in the same leg, that increases the risk of PTS with the current DVT about 2 to 3-fold. Patients with elevated body mass index and those with older age have also been shown to be at higher risk of developing PTS, as have those who have primary pre-existing varicose veins or primary venous insufficiency. And in some work that our group did, we were also able to show that the severity of symptoms and signs at the time of acute DVT, namely the severity of symptoms in the affected leg, do appear to increase the risk of subsequent post-thrombotic syndrome, maybe because more severe symptoms and signs represent a more exuberant inflammation response. And this has been shown to be a risk factor for PTS, not only in our own work, but in subsequent work by others as well. What's interesting is that factors that appear to have little or no effect on the risk of developing PTS include male versus female sex, whether the DVT was provoked or unprovoked, and whether a genetic thrombophilia is present. Now turning to risk factors related to the treatment of acute DVT. So it's interesting that the quality of oral anticoagulation, if you're using vitamin K antagonists, does appear to influence the risk of PTS, such that if your INR is subtherapeutic for 50% of the time or more, especially in the first 3 months of treatment, that increases the risk 2 to 3-fold. And perhaps because this represents less than optimal treatment of the acute DVT, and perhaps magnifies or stimulates damage to the vein wall and particularly the vein valves. In terms of choice of anticoagulant to treat DVT, when one is comparing a DOAC versus low molecular weight heparin versus vitamin K antagonists, we don't really have enough information to date. For example, it's not really known if using a DOAC to treat DVT influences the risk of PTS. However, there have been some retrospective analyses of a previously performed acute DVT treatment trial, which seems to suggest, although this requires further study, that rivaroxaban compared to vitamin K antagonists may lead to a lower risk of developing post-thrombotic syndrome. But conversely, a different retrospective analysis looking at edoxaban and dabigatran were not able to show that effect. So it remains a bit uncertain whether DOACs as a general class or whether individual DOACs do have any role in terms of reducing the risk of post-thrombotic syndrome. And in terms of low molecular weight heparin, there is a meta-analysis that suggests that if you use low molecular weight heparin alone to treat DVT, this may reduce the risk of PTS, perhaps because of some of the anti-inflammation properties of certain low molecular weight heparins. But this still deserves study in prospective trials, which have not yet been done. And in terms of using thrombolysis to treat the acute DVT, whether that prevents post-thrombotic syndrome, we'll be talking about that shortly in a subsequent slide. There are other risk factors that become apparent only during follow-up after DVT. So this includes ipsilateral DVT recurrence. If a patient after their DVT goes on to have a recurrence in the same leg, that leads to a 4 to 6-fold higher risk of developing post-thrombotic syndrome, probably by further damaging compromised vein valves or aggravating the venous outflow obstruction that goes on to lead to venous hypertension. In other work done by our group, we were able to show that if you still have symptoms in your leg and clinical signs 1 month after your acute DVT was diagnosed, that this also seems to be a marker of going on to develop post-thrombotic syndrome. And the more severe your symptoms were at 1 month, the higher risk of going on to develop PTS. And again, this may represent persistent inflammation or inadequate fibrinolysis such that there's persistent obstruction, so it could be a marker of those underlying pathophysiologic processes. Similarly, some studies have shown that if you have residual thrombosis on your ultrasound 3 to 6 months after your DVT, this may increase the risk of PTS. And persistent elevation of D-dimer in the weeks to months after DVT may be a modest risk factor for developing post-thrombotic syndrome. So our group tried to put together all of these various risk factors for post-thrombotic syndrome into a clinical prediction model that ideally would be used at the time the patient presents with their DVT to enable us to predict their risk of PTS. And we derived this model using the SOX trial data, and I'll mention the SOX trial a little bit later. And we were able to validate this model subsequently using the ATTRACT trial study cohort, and I'll be mentioning the ATTRACT trial also shortly. And we called this the SOX PTS index. And we found a number of high-risk predictors of PTS that could be ascertained at baseline. So patients get 1 point if they had an iliac vein DVT compared to a DVT in other aspects of the venous anatomy. They got 2 points if their BMI was above 35. And then they got 1 point if their Villa Alta score, which is a score that assesses post-thrombotic symptoms and signs, if it was high, 9 to 14 at baseline, and 2 points if their score was even higher, namely greater than 14 at baseline. And adding together all these points, if the sum was greater than 4, this predicted a 6-fold increased risk of post-thrombotic syndrome. So as mentioned, this index has been successfully validated in a subsequent population. And as to whether or not it's been taken up into clinical practice, it may be a little bit too early to tell, but I just wanted to let you know that this index is available for use. So we're going to move on to talk a little bit about how one can prevent the post-thrombotic syndrome, keeping in mind what we just discussed about the various risk factors for PTS. So the first thing that's really important, of course, is to prevent the initial deep vein thrombosis wherever we can. And this involves improving the systematic use of thromboprophylaxis in those patients who are at high risk for venous thromboembolism. So the high-risk patients in high-risk settings, such as surgical patients and other settings as well. It's also important, based on what I told you, to prevent ipsilateral DVT recurrence, because this increases the risk of PTS 4 to 6-fold. And the way one does this is by optimizing the treatment of the initial DVT, so making sure that you've used an appropriate duration of anticoagulation and appropriate intensity of anticoagulation to treat the initial DVT. And in addition, as I explained to you a couple slides ago, it's important, particularly if you're using vitamin K antagonists, to ensure good quality of anticoagulation for the DVT, especially in the first 3 months, because if your INRs are subtherapeutic, that does increase the risk of going on to develop post-thrombotic syndrome. So in addition to these preventive measures, what else is available? So do elastic compression stockings prevent post-thrombotic syndrome? And there were a couple of older open label trials done in the 1990s and early 2000s that reported that if you wear a 30 to 40 millimeter mercury knee-high stocking for at least 2 years after a proximal DVT, that you could reduce your risk of developing post-thrombotic syndrome by half, namely by about 50% in these trials, down to 25%. Our group subsequently performed a large multi-center placebo-controlled trial of patients with proximal DVT. This was a CIHR-funded study. And again, we compared active stockings, namely 30 to 40 millimeter mercury knee-high stockings, to a placebo stocking that looked and felt exactly the same as the active stocking, but had barely any compressive effect. And we were not able to show any benefit of these knee-high compression stockings worn for 2 years, either to prevent the post-thrombotic syndrome, to reduce the risk of recurrent venous thromboembolism, or to improve quality of life. And I think based on those more recent clinical trial data that our group was involved with, the more recent treatment guidelines now no longer recommend the use of compression stockings to prevent post-thrombotic syndrome. And I'm going to just show you what the ACCP 2021 guidelines, which are now in press, wrote. They say in patients with acute DVT of the leg, we suggest against using compression stockings routinely to prevent PTS. And in the ASH 2020 guidelines, again, for those with DVT, whether or not they have an increased risk of post-thrombotic syndrome, we suggest against routinely using compression stockings. But then they go on to say that although the majority of patients may not benefit from stockings to reduce the risk of PTS, stockings may still help as a form of reducing edema and pain associated with DVT, and we'll be talking about that a little bit later. So in terms of how I use stockings in my practice, based on the available data, I don't routinely prescribe stockings to all my DVT patients. This is because they're hard to put on, they're uncomfortable, they're expensive, and they need to be replaced every few months. And also, many patients won't wear them in real life, especially if they have no symptoms. But I do prescribe a trial of stockings to DVT patients who have residual symptoms after their DVT, namely swelling, heaviness, or discomfort. I start off with a 20 to 30 millimeter stocking because it's easier to apply, and I simply continue them for as long as the patient feels that they are helping them or is able to tolerate them. What about the use of thrombolysis to prevent post-thrombotic syndrome? We're going to be briefly discussing the results of the ATTRACT trial, which was published in the New England Journal in 2017, and looked at the use of pharmacomechanical catheter-directed lysis to treat acute proximal DVT, whereby it was a combination of infusing a lytic agent along with a physical device that sort of macerates and aspirates the clot occupying the vein lumen. So in terms of the concept of DVT care and where thrombolysis fits in, I mentioned earlier that anticoagulant therapy is necessary but not sufficient to prevent post-thrombotic syndrome, and compression stockings are not sufficient to prevent post-thrombotic syndrome. So this leads us to the open vein hypothesis, whereby perhaps restoring an open vein very quickly will help the patient by preserving venous function and preventing the development of post-thrombotic syndrome. So in terms of the ATTRACT hypothesis, it was that PCDT, or pharmacomechanical catheter-directed lysis, will reduce the risk of future post-thrombotic syndrome by 33%. Patients were randomized to either receive PCDT or no PCDT, and all patients got anticoagulation and were prescribed compression stockings and were followed for 2 years. And the primary outcome was post-thrombotic syndrome, defined by a Villa-Alta scale of 5 or greater. And I don't have time in today's talk to review the Villa-Alta scale, but essentially it's a way to diagnose the post-thrombotic syndrome that takes into account patient symptoms and signs, each of which are given a severity grade. You add up the points, and if it's above or equal to 5, the patient is considered to have post-thrombotic syndrome. In terms of the patient study, there were 691 patients. 57% had pretty extensive DVT in the common femoral or iliac veins. The mean age was 53, and patients had symptoms for an average of 6 days before randomization. And I'm going to show you in the next couple of slides the short-term and the long-term results. So in terms of the short-term results, you can see that patients who received PCDT had a higher risk of major bleeding and any bleeding. And there were modest differences in favor of PCDT in terms of improvement in leg pain and swelling within 10 days or 30 days. But numerically, these are actually very small differences, although they were statistically significant. In terms of the primary outcome of the trial, the post-thrombotic syndrome, you can see on this slide that there was no difference between the PCDT and no PCDT groups in terms of the primary outcome. It occurred in 47% and 48% respectively. However, in secondary analyses, moderate to severe post-thrombotic syndrome occurred in only 18% of the PCDT patients versus 24% of the no PCDT patients. And while the p-value for this difference was 0.035, the pre-specified cutoff for significance for secondary analyses in this trial was 0.01. So this was not considered to be a statistically significant result. And you can also see that most of the benefit here appears to be driven by the iliofemoral DVT subgroup. That's where you see the greatest difference. So to conclude, PCDT is not indicated for routine use in proximal DVT because it does not prevent post-thrombotic syndrome and it does increase the risk of bleeding. And further study and clinical use should be targeted. We know that PCDT likely reduces acute symptoms and PTS severity, and maybe iliofemoral DVT patients, because they have a higher risk of PTS, they have a greater PCDT effect. And one can always anticoagulate first for the 5 to 7 days if the limb is not acutely threatened. There's subsequently been another trial that confirmed the ATTRACT results, namely the CAVA trial. And just moving on to the guideline recommendations, the most recent ones, ACCP 2021 and ASH 2020, you can see that in patients with acute DVT of the leg, it's suggested to use anticoagulant therapy alone over interventional approaches. And it's always reasonable to do this, at least at first, and then see how the patient does. And thrombolysis is reasonable to consider for patients with limb-threatening DVT. An example of that is shown on this slide. This is a patient with phlegmasia cerulea dolens, and it's to remind us that there are clinical situations where thrombolysis is definitely indicated. So just going to move on in the last few slides to treatment of PTS. It's a very short part of the talk because unfortunately the options are very limited. Overall, the goals of treatment are to relieve symptoms and improve quality of life, prevent clinical worsening, and prevent and manage ulcers, which are beyond the scope of today's talk. We do use stockings to relieve symptoms of PTS. And the only point to make here that's important is that they do require strict compliance to maximize effectiveness. So we ask patients to put them on in the morning, remove them at the evening. We usually prescribe knee-length stockings. And if the 20 to 30 millimeter is not strong enough, we can go on to a higher strength stocking. There are intermittent compression devices to treat moderate to severe PTS, as shown on this slide. There's the VenoWave device, as well as pneumatic sleeves. And when we look at the guideline recommendations on the use of compression to treat PTS, the most recent guidelines that address this question do say that a trial of stockings should be used in patients with PTS who have no contraindications, and that if patients have moderate or severe PTS, one could try intermittent compression with one of those two devices that I showed you. In terms of medications to treat PTS, we did a systematic review some years ago now, which showed very low quality evidence for the effectiveness of various so-called venoactive medications. We're about to start a CIHR-funded trial called the Muffin PTS trial that's going to be looking at micronized purified flavonoid fraction, a venoactive drug that appears to have a mechanism of action most relevant to treat PTS. And it'll be a multi-center double-blind trial that will evaluate the effectiveness and safety of a 6-month oral regimen of this drug. We expect the trial to be starting up in the next month or two. We've also done some pilot work looking at the value of exercise training to treat PTS. And in this small pilot trial that looked at a 6-month program of strengthening, stretching, and aerobic exercise in patients who had post-thrombotic syndrome, we were able to show that quality of life was improved, leg strength and flexibility was improved, and the PTS scores trended towards improvement with this 6-month exercise regimen. And based on that, limited pilot data, the guidelines in AHA in 2014 did suggest that one could consider a supervised exercise program for patients with PTS. Just some basic other common sense lifestyle considerations for patients with PTS. Try and maintain a non-obese body weight, keep active, keep your legs elevated when you can, and try to avoid skin breakdown to prevent venous ulcerations. And I just want to make one mention of the fact that some patients do have severe and very severe post-thrombotic syndrome. And, this is beyond the scope of today's talk to talk about this in detail. But, if your patient does have substantial disability and daily life limitations, it's appropriate to consult with an endovascular specialist who has experience either with endovascular techniques or even surgeries to treat severe PTS. But one of the caveats is that well-designed trials have not been performed to date, and there's a lot of inter-institution differences in outcomes with these various techniques. So we're actually in the middle of conducting the NIH-funded CTRACT study, which will be a randomized trial to compare endovascular approaches like stent placement and saphenous vein ablation to conservative approaches for relief of moderate or severe post-thrombotic syndrome. And this trial is now underway. So to sum up the clinical reality of PTS, it's not just a cosmetic or a nuisance problem. I think that healthcare providers have tended to underestimate its incidence. Most DVT patients have never been told about PTS, and doctors should be monitoring their DVT patients for PTS during follow-up. Always like to talk about research. So these are some specific areas that do require research. I won't read each of these points, but for those of you who are trainees or young researchers, I would encourage you to get involved in this research domain because there's a lot of work done. And in my final slide, I just want to mention once again that the ISTH 2023 Congress will be taking place in June 2023 in Montreal. We expect upwards of 8,000 to 10,000 delegates. And Mark, Roger, and I at McGill are the Congress co-chairs. This is the recently convened local organizing committee, and I hope to see as many of you as possible at our Congress. Thanks again for inviting me to talk at your conference today, and I will now exit and stop sharing my screen because I think there's a Q&A session.
Thank you very much, Dr. Kahn. We'll start with, I think Dr. Conway has some questions lined up for you.
Hi, Susan. To see you from the distance. The first, I'll just start with a question from Renee, who says, thank you for the fantastic talk. There are some trials ongoing comparing above versus below knee and 25 versus 35 millimeter mercury stockings for PTS prevention. Do you think these will really make a difference?
So good questions. So I know that there's already been a trial published by Kahn looking at above knee versus below knee showing no difference in terms of risk of post-thrombotic syndrome. So I wasn't aware that there's an additional trial, but thanks for I'll look into that on the trial registry. And I believe there was the Celeste study that compared the lower strength to the higher strength stockings that was presented at the last ISTH. I'm not sure if they just presented their protocol or actual results. But I guess one of the points that I would make is that that's not really answering the question of whether one needs to wear stockings at all. And there is an ongoing trial, the CHAPS trial in Britain. It's sort of a replication of the SOX trial that's looking to see whether active stockings versus no stockings have any role in preventing the post-thrombotic syndrome. So to me, that's the first step, determining whether you need to wear a stocking at all. And then if you do, you know, what's the right length and what's the right strength?
So pathophysiology, at least is clearly a favorite thing to do when you're giving violence. And so are other anti-inflammatories being considered? And can you comment on the role of statins?
Oh,
there you go.
Okay. So actually, in the SOX trial that I presented to you, was actually originally designed as a factorial design trial where patients were randomized to 30 days of Celebrex versus placebo, and then in addition, they were randomized to active versus compression stocking. And unfortunately, a few months after the trial started, there was information in the press about how rofecoxib, a different COX-2 inhibitor, was linked with cardiovascular adverse events. And there were also some reports similarly with Celebrex. So we actually had to abandon that intervention within the SOX trial, although I still think it would be very interesting to look at the possibility of using an anti-inflammatory medication early on, the first 2 weeks or 4 weeks, to see whether that could influence the underlying pathophysiology and reduce the risk of PTS. In terms of statins, we're actually just about to start a multi-thousand patient randomized trial, also funded by CIHR, called the SAVOR trial, which is going to look at randomizing patients with acute thrombosis to be on rosuvastatin, a low-dose statin, for the duration of the trial. So it could be upwards of months or even years while we participate in the trial versus placebo. Because statins do have certain anti-inflammatory and vascular, modulating effects. And there's some observational data that suggests that there could be a benefit at reducing the risk of PTS. And I think it was also looked at in one of Paul Ritker's trial as a secondary outcome. Statins trial that seemed to show that the risk of DVT may be reduced. So this is going to be a trial, the SABRE trial, designed specifically for the purpose of seeing whether statins may have a role, in addition to anticoagulation, in reducing the risk of post-thrombotic syndrome.
About the incidence of PTS in pregnancy, and are they at higher risk?
Great question. And I have to say that many of my worst PTS patients are young women who got pregnancy-related DVT, and that's probably because we know that in pregnancy, DVTs often start in the proximal veins because of the enlarging uterus, compared to other types of DVT, which typically start low down in the calf veins and then grow up proximally. So because pregnant women with DVT tend to have, higher proximal or more anatomically extensive DVT, I think that's why, many of them are at higher risk of developing post-thrombotic syndrome.
These trials, are any biomarkers, some serial biomarker studies being measured to identify, using mass spec or whatever, to identify changes and over time?
Sure. So in our SOX trial, we had a separately funded biomarker sub-study where we measured various inflammation markers at time 0, 1 month, and 6 months. And, we were only able to measure a limited number of factors, and maybe they weren't the most sophisticated, and maybe there's additional factors or even gene polymorphisms that could be measured now. But we were able to show that levels of IL-6 and ICAM at either baseline or 1 month, it did seem to be predictive of developing post-thrombotic syndrome, whereby patients with higher levels of these markers, independent of, adjusting for some of the other risk factors for PTS, did seem to be at higher risk of developing PTS. But you may have other ideas as to which markers we might measure if we were redoing the trial today.
Hello, Susan. It's your partner in crime, Cedric. A couple of things. One is if you give low molecular weight heparin per anti-10A units, you've got 3 times the weight of heparin. I don't know how that relates to the anti-inflammatory properties, but you did allude to the effect of low molecular weight heparin versus other anticoagulants downstream. I don't know if that's worth going back to, but that's a comment by way of passing. Now, the other thing that I've always sort of grappled with is the microcirculation. The capillaries, they deliver it. The lymphatic system picks up 50% of the extracellular fluid and puts it back in. Is there any interest in that, or any mileage in looking at that, or can you even look at it?
Sure. So I think there's a kind of a small literature suggesting that some of these symptoms and signs of post-thrombotic syndrome may be attributable more to, lymphatic disruption or dysfunction. And I believe that my colleague, Mary Cushman at University of Vermont, and one of her colleagues there, whose name I'm blanking on, actually did a small trial looking at lymphatic drainage therapy to see whether that could improve post-thrombotic syndrome. And, it was a pilot study, and maybe there was a small signal there. But beyond that, I don't have any particular insights into, to what degree lymphatic disruption may influence the post-thrombotic syndrome. Thank you, and nice to see you, Cedric.
Thanks for the nice talk. I'm wondering if there's much data on aspirin and post-thrombotic syndrome, because I know sometimes it's used, it's a bit more mild, obviously, than like stronger NSAIDs like Celebrex. So I'm wondering if that might be an option or if there's any trials going on.
Yeah. So you're right that aspirin has some anti-inflammatory properties and also some anti-thrombotic therapies that are, less so than with the DOAC. So I think in general, we're not really using aspirin anymore, for example, for secondary prevention of recurrent thrombosis. But we had considered using aspirin in the SOX trial as the anti-inflammatory intervention. I think because we were concerned about, use of aspirin along with an anticoagulant, that there might be a higher risk of bleeding. And that's why we chose Celebrex. But I'm not aware of any specific literature that has looked at that.
Okay, thank you very much, Susan. That was a fascinating talk, and I think we've exhausted